A 44-year-old Indian American presented for cataract surgery in his left eye. There was evidence of a hypermature brunescent cataract with a vision of perception of light in the left eye. The right eye showed evidence of perfect pseudophakia with a multifocal IOL. A retina examination did not give any fundal view. A B scan revealed a normal-looking retina. Specular microscopy was done, which was also normal. The patient was counseled for cataract surgery, and because of the presence of a multifocal in the right eye, it was almost a do-or-die situation, whereby it was decided to do a Zepto capsulorhexis and proceed for cataract surgery in the left eye. A 2.2 mm corneoscleral approach was undertaken. The calcified anterior capsule was stained with trypan blue, and the AC was filled with viscoelastics. The silicone suction ring of the Zepto was introduced into the anterior chamber after a little manipulation. Care was taken to place it carefully on the capsule as perfectly central as possible, after which gentle suction was applied, which was visible by the way water molecules were removed. After adequate suction, the Zepto laser was applied, which was visible as a lightning flash. It was quite obvious that the capsulorhexis was complete, but were my problems over? Or was it that simple? This was the first time I was using a Zepto for a capsulorhexis, and it was being demonstrated. I was told that the suction had been removed, and I was instructed to remove the suction ring. But it came as a bit of a shock when I realized that, in spite of being told that the suction had been put off, the suction ring was attached to the anterior surface of the lens, almost like a magnet. I was again asked to try and manipulate the suction ring out of the anterior chamber, which I tried to do. In fact, I thought probably it was something that had gone wrong in my technique. I put in a second instrument and tried to break the suction. However, that was not possible. I went in with a visco cannula through the side port and pushed in a little bit of viscoelastic to stabilize the anterior chamber. But no matter what I did, the suction ring was absolutely stuck to the anterior surface of the lens. Being a hypermature cataract, there was practically very little room to maneuver, and no matter what I did, the zonule was looming dangerously at the 6 o'clock position whenever I gave a little pull. I exchanged hands, held the suction ring with my left hand, and with my right hand placed a second incision on the nasal aspect of the cornea, anticipating problems. It was then decided to disconnect the tubing and push 1 cc or so of BSS solution through the tubing, and lo behold, this was visible with the gush of fluid and viscoelastics through the side port. The vacuum was released, and to my relief, I was able to remove the suction ring slowly. After taking a few deep breaths, it was decided to proceed with a stop-chop mechanism of phaco in this very hard, leathery brown, hyperbrunescent cataract, which I did in a slow, controlled manner, rotating the cataract smoothly. Viscoelastic was pushed in through the side port to deepen the anterior chamber and to reduce any chance of damage to the endothelium. Very limited amount of epinucleus was removed and viscoelastic was placed once more. There was hardly any soft lens matter. The one marvel of the Zepto was that the edge of the capsular rhexis was sharp, clear-cut, well demarcated and almost surgically incised. Small amount of soft lens matter was still present, which we removed with irrigation aspiration. The Zepto CCC was a joy to behold. After deepening the anterior chamber, an apodized diffractive multifocal foldable IOL was placed without much need of dialing in. The intraocular lens made its way into the posterior capsular bag. Irrigation aspiration behind the intraocular lens was done to remove all viscoelastics for better, effective lens positioning. Stromal hydration was done, which revealed a tight anterior chamber, a well-placed intraocular lens. Post-operatively, the patient did very well with 6/6 part unaided vision reading N6 for near. All's well that ends well.